Hello, I'm Dr. Bill Gradishar, Professor of Medicine at Northwestern University, and I'm pleased to be participating in this Yerba YouTube video on scanning for patients with early stage breast cancer. One of the most common questions that I encounter in clinic when I see patients with early stage disease, particularly when they've completed their therapy, be it surgery or adjuvant chemotherapy, whatever the circumstance may be for that patient, is the very common question, how will you know that you got it all, or how do I know that it's not going to come back? Which is a segue to saying, aren't we supposed to be doing a lot of additional testing and doing it frequently? And I think this is always a concern of patients, that they want to know that their disease is completely eliminated. And it's a very challenging thing to discuss with patients because there is no perfect test that tells us that the disease is gone and won't come back. Keep in mind that when a patient undergoes surgery, all the visible disease is removed. And anything that comes after that is really with the intent of removing microscopic disease. Microscopic disease is not just located in the tumor bed where the original tumor was located, in this case the breast, but it also circulates in the bloodstream. And we know that circulating tumor cells can go sit somewhere and do nothing for years, and then at some later time point become active by mechanisms we don't understand. And that's what leads to a recurrence in an individual patient. Now, the purpose of any of the therapies that we give, be it anti-hormone therapy, chemotherapy, or HER2-directed therapy, immunotherapy, these are all treatments that are meant to eradicate microscopic disease that could be there. We don't know that it is, but based on certain features of the patient's circumstance at diagnosis, we may feel that they meet a threshold where that kind of therapy is recommended. Now, once a patient has completed their therapy, as I mentioned, patients always want to know, was the therapy effective? Keep in mind that when the therapy is administered, there is no evidence of disease. There's nothing that would indicate that we're treating anything objectively. In other words, you don't have a scan that shows that you have a 2-inch tumor because the surgery removed the tumor. So in the circumstance where you have completed your therapy, the common question is, should I be getting blood tests? Should I be getting tumor markers? Should I be getting a PET scan or CT scan? And the answer to most of these questions, in the absence of symptoms that are new and different and concerning, is no. It hasn't been shown that by doing frequent imaging, and again, I'm making reference to things like CT scans, bone scans, PET scans, etc. In the absence of symptoms, these tests do not generally show us anything that we didn't know without the scans. And they don't offer the level of reassurance that you might think they would, because again, scans don't show microscopic disease. And the other thing that is a downside to getting scans is that the more scans you get, the more things you find. And again, the reason that is stated that way is because scans show incidental things. And somebody that has a diagnosis of cancer, these incidental things not infrequently lead to additional tests and potentially biopsies, all of which generally don't show anything. So we try to be very conservative about the use of scans in the absence of symptoms, because they don't actually help us help the patient in the vast majority of cases. CT scans can increase your exposure to radiation therapy. So over time, unless there's a good reason for doing these kinds of scans, we try to limit that. We know, for instance, in patients who get radiation therapy to their breast, there can be some changes in the lung. So CT scans may artificially show something that's an abnormality, but not related to the disease, but related to radiation therapy. So we have to be very careful about ordering tests and understanding what information it's actually providing to us. Not only may you get false positives, not only may you get an increased exposure to radiation therapy, but you're not necessarily offering the patient the reassurance that they need. We tell patients that if they develop new symptoms, we wouldn't hesitate to pursue them with the appropriate testing at that time. We also tell patients that if you have a new symptom, you have an ache or pain, and it goes away within a day, we don't really care about things that go away. It's things that are persistent or that escalate over time that we really pay attention to. You're going to get the aches and pains of day-to-day life. We just want them not to be different than what you're normally experiencing, or if it's something new, that it goes away. If it doesn't, it should come to the attention of your physician, and they can make a decision with you about the appropriate testing that should be done at that time. The other issue is routine blood tests. Should I be getting those? Well, once you're done with therapy, unless there's some other medical condition that requires getting blood tests, again, in the absence of symptoms, we don't typically check blood tests because they're a very crude way of looking for anything related to the cancer. A more granular type of test that patients commonly ask about are tumor markers. And these can be circulating proteins that can be detected in the bloodstream that are, again, not particularly specific to the breast cancer that the patient had been diagnosed with. And we don't routinely do these. They are something that one could do, but the blood test results from tumor markers can go up, they can go down, and that's over time with nothing else going on. So you can make patients very anxious rather than easing their anxiety. You can actually increase it by getting tumor markers and watching the numbers fluctuate. And that, of course, then leads to yet additional tests looking to try to explain why the markers are changing. Now, for patients who have breast conservation, of course, they are going to get mammograms. They're going to get the appropriate annual imaging of their breast. But in the setting where you're asking, has the disease come back somewhere else, we don't do imaging routinely. So there are circumstances where these kinds of tests can be useful. And as I mentioned, in patients that have new symptoms, we wouldn't hesitate to get the appropriate testing. There can be patients where they have bone-only disease, and you're trying to understand whether or not the disease is changing in somebody in a very different setting with metastatic disease. Then perhaps a tumor marker could be helpful. But for the vast majority of patients with early stage breast cancer, systemic scanning is not recommended. Routine blood tests, unless there's a reason to be doing them, is not generally recommended. But if something changes, then all of those things would be a consideration. If you'd like to get more information about personalized treatment paths, including the different therapies that are available that might be appropriate for your situation, tailored to your tumor biology and health profile, you can get a Yerba report which breaks down chemotherapy regimens, endocrine treatments, and other combinations, and provides specific information that may be appropriate for your case. And you also have an opportunity to interact with Yerba's medical experts directly for evidence-based answers about your options, recurrence risk, or side effects from the therapy you have by going to yerba.com. For patients with early stage breast cancer, the follow-up is usually dependent on how far out they are from the diagnosis. Typically in patients with newly diagnosed early stage breast cancer, we see those patients once they completed chemotherapy, if that was appropriate for them, every 3 to 4 months. And then as time goes on, we spread that out to every 6 months. And then after 5 years, it may be once a year, or patients are transitioned to survivorship clinics if those are available to you. Among the things that we're looking for, above and beyond obviously any suggestion that the cancer could be active, is any evidence for a local recurrence. So obviously a clinical exam is always important when you're seeing your physician. Obviously an exam of the breast. Patients should continue to get mammograms if they have intact breast tissue. And again, as I mentioned earlier, the use of additional scans is only predicated on whether or not there are new symptoms or suspicions. We always take into account any side effects that patients might be experiencing as a result of perhaps taking adjuvant endocrine therapy These are drugs that are given to patients with ER-positive, hormone-sensitive breast cancer, and they may be continued for 5 years or more. And any of these drugs potentially have some side effects, including things that affect bone health. So we ask symptoms, any symptoms that may be related to expected side effects, and if that's changed over time. Obviously, we have to monitor bone density in such patients as an example. But tamoxifen as a drug can cause a variety of side effects. Most patients find the drug reasonably well tolerated, but some patients experience hot flashes or a light vaginal discharge. So there can be any of a number of symptoms that we have to survey as we talk to a patient, because in order for the patient to stay on the therapy, in order for them to get the benefit of the therapy, they have to adhere to the therapy. And making it as acceptable to them day to day is critically important. So I'd like to conclude this YouTube video by Yerba. I hope that this was helpful to you. This was obviously a discussion focusing on something that's very common, a concern of patients, and that is how should I be followed over the long term? And you can visit yerba.com for additional information. Thank you.